Good morning, good afternoon, good evening, all our colleagues and friends all around the world and Australasia that are logging in today. Thanks for joining us today for another series in our TAPS program. For those that are joining new, TAPS stands for the Australasian Pleural Seminars. This is our kind of initiative to get everybody together and talk about improving clinical care and getting together people to discuss research as well. So thank you for joining us today. Remember, these sessions are recorded, so feel free if you've missed previous ones to get on to YouTube and then catch up. We have a great series of speakers. And with that, today I'll introduce Dr. Claire Tobin. She's going to be speaking about thoracic ultrasound today, a topic that's near and dear to my heart. She's a respiratory consultant at the Royal Perth Hospital, head of department and pleural lead there. And importantly, one of the things she's contributed importantly is her book on pleural ultrasound for clinicians. I think, for anybody that hasn't read it, and it's definitely starting out new, an amazing resource really to highlight and kind of review what you need to know before you jump into thoracic ultrasound. But without any further ado, I'll turn the camera and speakers over to Dr. Claire Tobin and have her talk about her topic today.
Thank you. Thanks very much for the kind introduction, and thank you for the opportunity to speak to you all today on the essentials of thoracic ultrasound. This is obviously a big topic, and so I'm going to focus on the need for physician-led thoracic ultrasound, talking about specific benefits in pleural disease management with a focus on effusions, pneumothorax identification, and pleural procedures. We'll touch on some up-to-date recent evidence on ultrasound-related trials, and then I will talk through what I often find are the 10 most common mistakes made when we're performing and starting out in thoracic ultrasound. What I won't be discussing are the basics of ultrasound, so in terms of the physics and image acquisition. You can get that from texts and papers. The images and videos that I'm using in today's talk are from my textbook, but where I've used other images, they're referenced. I suspect I may be really preaching to the converted with the majority of this audience, but ultrasound now really as a point of care test has significantly changed how we as respiratory physicians, but also how acute and critical care physicians accurately manage patients and guide patient care. Competence in performing thoracic ultrasound is an obligatory part of respiratory specialty training programs in many parts of the world, and as outlined here, offers several advantages to other imaging modalities. When we think about pleural medicine, long gone are the days where ultrasound was purely used to identify the presence of fluid. It now helps us support the entire patient journey from initial diagnosis through clinical treatment strategies and prognostication. So really helps us tailor patient-centered care. We use it as an extension of our clinical examination now, really at the bedside, which allows on-the-spot decision-making and therefore improves and streamlines the patient pathway. What I think many of you will be familiar with is a vast amount of data and research now looking at the improvement in patient safety with regard to the use of ultrasound for pleural procedures, because it ensures the appropriate, accurate, and safe access into the pleural space. And for those that have increased experience and competence in using ultrasound, we can plan and execute more advanced diagnostic and therapeutic intervention in terms of real-time guidance for procedures and biopsies or use in medical thoracoscopy. When we think about effusions, ultrasound can help us determine whether an effusion is real. It evaluates the size of the effusion and the effect on diaphragm function. It can help us to determine the character of the fluid, and by that I mean whether it's anechoic or echogenic, simple or septated. It can help determine the pre-procedure probability of specific etiologies, predominantly malignant disease or infection, and can also help guide outcome prediction of various interventions. And I'm going to talk through each of these in a little more detail now. We must be aware that there are ultrasound mimics of pleural fluid. So there are other causes of an echo-free space, and that includes scanning directly over a rib. So poor use of your settings. So if you set your TGC, which stands for time gain compensation, incorrectly, you are going to get a false appearance of a dark screen in the near field. If you have malposition of underlying organs, so for example, in a patient that has a dilated cardiomyopathy, their heart may completely abut the chest wall and can give rise to an echo-free space. If you have pathology below the diaphragm, such as ascites or a liver or renal cyst, if you haven't confidently identified the location of the hemidiaphragm, that fluid is going to get misinterpreted as representing a pleural effusion. There are also causes of an echogenic space, which include the spleen and a stomach that's distended with fluid. And actually, it's not uncommon for novice scanners to look at a spleen and think they are looking at an echogenic effusion. In terms of pleural effusion size, on a practical day-to-day basis, we really do this by assessing the depth of the effusion, so the distance from the parietal pleura down to the deepest point of the fluid, and the height in terms of rib spaces. There have been a variety of calculations used to estimate the volume of fluid. The equation that I've outlined here has been shown to be the most accurate, where H is the depth of the fluid, as I outlined, and C is the distance between the apex of the hemidiaphragm and the bottom of the lung. You can see in this image here, this is a small effusion where you've maintained the correct or normal structure of the hemidiaphragm, which is convex towards the thorax. As the effusion increases in size, this has an effect on both the shape and the functioning of the hemidiaphragm. So we move from this normal curved structure to flattening of the hemidiaphragm and ultimately an inverted hemidiaphragm. And you can see an extreme example of this on the CT scan here in a complete whiteout. When the effusion becomes flattened, when the hemidiaphragm becomes flattened or inverted, you can then start to see abnormal motion of the hemidiaphragm. So rather than it contracting and moving downwards during inspiration, it can move upwards during inspiration. And this is called paradoxical movement. I apologize, I had a video of this, but had to remove it because it crashed the entire presentation. But these features in terms of shape and movement of the diaphragm are really important to note, because abnormality has been shown to be independently associated with relief of breathlessness post-drainage. And that was shown by Gary's group in the initial PLEASE study. Next, we move on to assess effusion character. By that, I mean echogenicity and the presence of septations. And that's important because both of these features can help us to suggest a potential underlying etiology as to the cause of the fluid. When we think about echogenicity, it can help us determine whether the effusion may be transitive or exudative. The presence of the so-called swirling sign has been shown to be quite highly sensitive for an exudative effusion and a predictor of possible underlying malignant disease. Homogeneously echogenic effusions can often be seen when there's blood or infection in the pleural space, and those appearances can become more complex, particularly if there's pus or purulent material in the pleural space and when air is also present. Septations occur when fibrin strands form within a fluid collection, and these may be seen as early when they're thin and mobile, meaning they move with cardiac and respiratory motion, versus more advanced where they're thicker and less mobile. And septations often indicate the presence of infection or malignancy and therefore have various diagnostic and therapeutic implications. We must note, though, and remember that any effusion that's been present for a particularly prolonged period of time, even transitive effusions, can have septations. This is an example of echogenic swirling. So you can see echogenicity within the fluid and the motion with cardiac and respiratory movement. To the left, you see early septations versus later septations on the right, which are thicker. Then this is an image of a more complex pleural space with increased echogenicity and multiple septations. There are some features identified on ultrasound scanning that are highly suggestive or pathognomonic for malignant pleural disease. And these include pleural thickening, pleural nodularity, diaphragmatic thickening, and the presence of hepatic deposits or infiltration of the chest wall. And in combination, these have a high sensitivity of 79% and specificity of 100%. It can be quite difficult to differentiate pleural thickening from an effusion because they both can appear as an anechoic or hypoechoic space between the parietal and visceral pleura. And in this situation, you can use Doppler scanning to help you. I also think it's really important to assess the underlying atelectatic lung for potential pathology as to the clues of the cause of the effusion. So here is an example of malignant pleural thickening between the two arrows that you can see with an effusion. Here we have an example of pretty large malignant pleural deposits sitting on the hemidiaphragmatic pleura. Here we can see mets within the liver and the effusion above the hemidiaphragm. And in this example here, we have a small anechoic effusion with underlying lung, which is consolidated. You can see it has a similar appearance to the liver. This is a term we call hepatization, and then an abscess within the lower lobe. When we think about the utility of ultrasound for pneumothorax identification, I think this is often ED and acute physicians may feel more comfortable with this, but I think this is important for us as respiratory and pleural physicians, particularly in the context of intervention. So both B and M mode scanning are helpful in pneumothorax detection. And sonographic features of a pneumothorax include the absence of lung sliding, the presence of comet tails, which are these short path vertical reverberation artifacts which occur from the bright pleural line, the presence of A lines, which are illustrated in the image below, which again are reverberation artifacts, but horizontal this time, which occur equidistant from the pleural line, the absence of lung pulse, and visualization of the lung point. Again, really important to know that there can be mimics of an ultrasound in pathologies that cause absent lung sliding. And those include severe emphysema or bullous disease, pleural inflammation with adherence, and pleurodesis. Here's an example of what things look like when using M mode scanning, which stands for motion mode. So in normal lung, you have no movement through the chest wall. You have movement at the pleural line and distal to this. So in M mode, you see this as what's called the seashore sign. Versus in a pneumothorax, the whole, there is no motion through this line here in M mode scanning. So it appears as what's called the barcode sign. I suspect you will all be pretty familiar with the use of thoracic ultrasound for procedures. I think it's important to remember that ultrasound in this context can be used pre-procedurally, peri-procedurally, and post-procedure. So when we think about pre-procedure, ultrasound helps identify the safest and most suitable site for intervention. And that may be through use of identifying exposed or vulnerable intercostal vessels. And we do that through using the linear probe and Doppler scanning. Identifying the largest pocket if the effusion is septated to help us site our drain in the most suitable location. Ultrasound can help identify tethered lung, which clearly we would want to avoid traversing with a needle or a drain. And then presence of safe ultrasound features to proceed with pleuroscopy. So that includes not only safe access point into the pleural space if fluid is present, but if you work in a centre that artificially induces pneumothorax, if there's minimal fluid present, ultrasound can be used to ensure appropriate lung sliding, meaning there's no pleural adhesions and that the lung is going to fall away freely to provide safe access into the pleural space. Peri-procedure, we can use real-time guidance, both in terms of accessing the pleural space if you're inserting a drain, for example, but potentially also real-time guidance with biopsies. Post-procedure, I think it's really important to get into the habit of screening for any immediate complications, which can really help you facilitate timely management and avoid a potentially life-threatening complication. So that may be to look and assess for bleeding from intercostal vessel damage or development of a pneumothorax. This is an example using Doppler scanning of an intercostal vessel seated deep in the chest wall. Similarly here, using Doppler, you can see it's identified a bleeding site from the parietal pleura puncture site. And this is an example, quite extreme example of tethering of the lung to the chest wall, which clearly you would want to avoid in any aspect of pleural intervention. Ultrasound has been shown to be useful in prognostication. So it's been shown to have use in prediction of symptom benefit, as I've already outlined in the PLEASE study and the effect of effusions on diaphragm. It's been shown to have potential use in identifying non-expandable lung through identification of reduced movement of collapsed lung using M-mode assessment. And this can be really helpful to identify early the most appropriate definitive therapeutic option in patients with malignant effusion in terms of whether they might be more suited to an IPC versus TALC pleurodesis, and that can help avoid them having multiple procedures. Ultrasound's been studied in looking at the success of pleurodesis by early identification of cessation of lung sliding and the use that may have in terms of timely drain removal post-pleurodesis. And finally, reaccumulation rate of malignant effusions post-high volume aspirate. There's been a more recent study showing that effusion depth on ultrasound pre-procedurally to be an independent predictive variable for the need for repeat intervention. So I hope that I have persuaded those of you that aren't already routinely using thoracic ultrasound on a day-to-day basis that it really is an essential skill for pleural physicians, and we should be using it proficiently and routinely to guide patient care and minimise procedural complications. More advanced uses for ultrasound are being identified and researched. And obviously, supervision and credentialing are key components to safe practice. And I think it's really important that we have ultrasound champions within our department for education, training and support, not only of junior colleagues, but also of our consultant peers. We must remember, though, that ultrasound has limitations and pitfalls. And that's both in terms of operator factors and patient pathology factors. And I'd like to spend the last couple of slides talking about some operator factors and the 10 most common things that I find may go wrong when we're starting out in thoracic scanning. The first is poor preparation. So not having reviewed other imaging modalities that are available to you in terms of your patient, and not optimizing your environment. So you need to be in a darkened room and have good ergonomics between you, the patient, and the machine. Patient positioning is the thing I actually most commonly alter when I'm supervising juniors. And positioning really is essential for successful scanning. And small changes in patient position and posture can really improve the image quality that you obtain. We must have a systematic approach to image optimization to allow diagnostic quality images. And that includes setting and optimizing your depth, your focus, your TGC, time gain compensation, and gain. Similarly, if you haven't mastered probe orientation and appropriate probe handling and manipulation, you're really going to struggle to get diagnostic quality images. And this comes with time and practice. If you have not confidently identified the location of the hemidiaphragm, you're going to have increased risk of misidentification of organs and pathology, as I've already outlined. We've got to remember that ultrasound is a 2D scanning method, and we've got to build up a 3D picture in our mind of the pathology inside someone's hemithorax. So we must scan the entire hemithorax and both sides, rather than a more sort of scanning an area of fluid and a point and shoot approach for intervention. We've got to be confident that we can recognise normal anatomy and recognise and minimise any artefacts and normal artefacts that we see in thoracic scanning to ensure that we are interpreting the image that we obtain correctly. I think from a procedure perspective, juniors are often a bit too reassured sometimes by the use of thoracic ultrasound. So they've used the machine appropriately, they've marked an appropriate site, but then they don't adhere to standard best practice when performing pleural intervention. So for example, they use a completely touch-free technique. There can be quite a protracted time between ultrasound scanning and the actual procedure when people are starting out. And that obviously increases the risk of the patient repositioning and therefore affects safety and the success of intervention. And finally, a complex pleural space can be really difficult to interpret. If you don't feel comfortable in what you're seeing and can't clearly determine what you're seeing, remember to stop and go and get a formal scan. Radiologists do still exist, all right? We work really closely with them and they are a great resource for us to help learn and increase our skill. So don't be afraid to go down with your patient and learn from your radiology colleagues. And I want to end on this slide, which I thought was a really fantastic quote from an editorial in 2023, which states that ultrasound does not permit a precise diagnosis when considering only the image obtained. That is wholly the responsibility of an operator who needs good eyes to correctly interpret the image, good hands to adequately guide the probe and create a good quality image, and a good mind to understand the clinical situation of the patient and integrate clinical data with ultrasound findings. This is art. And I'll end there and welcome any questions. Thank you.
Yep. Okay. Oh, sorry, we just having a little technical difficulty here. But thank you to Claire for that amazing talk. I mean, really, one thing I'm going to go on a limb a little bit and maybe say something controversial, but I think, and I feel strongly about this, but I think it's, I mean, almost negligence to not use ultrasound and when you're doing any kind of thoracic procedures, any pleural procedures. So I feel very strongly about it, and I think, your talk kind of highlights the importance of why we should be, one, learning how to do it properly, and then kind of, continue to improve upon and really set up a service with it. I think it's not just a, put a probe on a patient and walk away, as you said in your last slide. There is so much to be had and done at the bedside when you're doing ultrasound. So with that, I'll start looking at some of the questions here. And so for our audience, please feel free to type in your questions and then we'll try to get through as many as we can. So Claire, the first question we have is, what level of training would you need the trainees to be at before they can be independent?
So I think that's multifaceted, actually. I think it's one thing potentially being competent with ultrasound. It's another thing being competent with procedures, and the two now go hand in hand. You can't train separately. So I think you need to assess juniors both. I'm not sure where that question came from, but there are a variety of outlines. I've actually put down here. I suspect people may be familiar with this, but the TSANZ requirements for being competent in thoracic ultrasound. I actually do use the UGSTAT assessment. I find it quite useful as a useful marker to gauge where juniors are coming in at. Often when they say, yeah, I've been doing procedures independently, I'm happy with ultrasound. There are always things, and this, when I self-reflect, again, there are always things that you can improve on. There are things that I think you don't know that you don't know until someone questions you about it. So I find that a really useful tool.
Yes, absolutely agree. And then the UGSTAT, I definitely second. I mean, those are validated kind of assessment tools that can be very helpful, and I think, underutilized, I think, for a lot of these things. And I think some of it is, there's not really a big push, at least in medical school, to teach ultrasound, I think, and that's one of the big detriments. And that's something that I'm passionate about, kind of creating a simulation and just a curriculum really for medical students starting on early. There's only one program a few years ago that I learned about in the US, at least, that was starting that. And I think more programs did, kind of follow suit. Because the way I learned, and I think a lot of people learned, is kind of just through practice, right? Through you going through rotations, you going through your training, you kind of just pick it up, and you don't necessarily always get kind of a detailed kind of step-by-step approach. And even just, some of the knobology, right? And some of how to optimize images and things, all the things that you were talking about.
I mean, I think that those are actually, although I've skipped over really most of that in this talk,
Mm.
those are the fundamentals that have to be learned, and are vital to facilitate you scanning moving forwards. And I think it's often the step that doesn't get taught because
Yeah.
it's it happens in real time. You're with a patient, you're by the bedside. You can't necessarily always afford the time it takes to go through that level of detail, but it really is important, which is why having texts that you can refer to that can take you through that in a step-by-step method, I think are important.
Yeah, absolutely. And Claire, I'll ask you, I'll get your thoughts on, so I mean, some places, resource-stricken locations, things like that, you can't afford, the Cadillac or the best image, the best big machine. But, with the advent of these smaller, tools, smaller kind of profile ultrasound devices, your thoughts and experiences, I mean, without, necessarily picking a name or brand or anything like that, but your
Yeah.
thoughts on these portable, smaller devices,
Yeah.
handheld devices versus, the large wheelie ones that you have to schlep around the whole hospital.
Mm. A good question. So we, like many other departments, I suspect, got handheld portable devices through COVID. And we occasionally use them, particularly in carded rooms, or if we've got to go across a particularly, large geographical area that's difficult to get the portable machine to. But I have to say, in my experience of the machine that I have, it doesn't provide as good quality images. So I think it's really helpful for assessing a patient. But if I would not use a handheld machine unless I really had to perform a pleural intervention. I would feel much more comfortable using the standard machine than a handheld machine. That said, I have used in other centres, I've seen different brands of handheld machines that I think are slightly different quality. I don't know what other people's experiences are in that regard.
Yeah, no, and I agree with you. I mean, I remember as a fellow, we had a handheld that I just kept in my pocket, and it was great because we had a very ancient old machine that was battery never lasted kind of thing. So it was always
Yeah.
nice to have the handheld. Again, for geographical locations, running around the hospital as a fellow, doing multiple assessments, it was great. But I agree. I mean, some of the image quality, you had to be careful with that. The image quality isn't as good, and kind of take it with a grain of salt. But great.
I
I'll
mean,
move
I
on to two
think.
more questions. What are the M mode and B mode features of unexpandable lungs?
Yeah, so when we talk about non-expandable lung, really the research that has been done on that has looked at a variety of features. And the M mode assessment of the underlying atelectatic lung has been shown to be the most accurate in determining whether that atelectatic lung is likely to re-expand. And so in studies that have been conducted, you look at the motion of that underlying atelectatic lung, usually during a breath hold, and assess the degree of motion with the thought that a more rigid visceral pleura is not going to move so well, and then it's obviously not going to re-expand. And so the cutoff in studies that have been assessed to use that have been a motion of less than a millimeter. And that's been shown with quite good accuracy to predict non-expandable lung.
Very good. Next question that I have up is, how do you measure pleural thickness? So I'm not sure exactly the details, but perhaps you could just talk about kind of landmarks maybe, or where to use, where to start kind of thing.
Yeah, so I mean, I think in terms of measuring anything, we need to ensure that what we see, number one, is indeed pleural thickening. And if we want to measure it, as we would perhaps want to measure an effusion depth or anything like that, we would freeze our image, we would use our calipers, and we would put the appropriate marks on the area of pleural thickening, and it will come up with a distance for you on the screen. So you would want to make sure you know what is your chest wall versus pleural thickening versus underlying effusion.
Right. And then, I'll ask another question is in terms of any resources locally or outside of that, you mentioned the UG Stat for assessment. Anything else online that you would recommend or local? I mean, there's always a handful of courses and things like that that you can attend, but anything that you would recommend for people that are starting out or maybe even seasoned experts to some degree?
Yeah, I mean, there's always courses locally or nationally that are that I think are actually quite useful to go to. Even if you're an experienced scanner, I think going to some of these courses intermittently, you will always generally take something away from them that you haven't, acknowledged or noted before. There are a lot of quite useful resources online, particularly for more novice scanners, but it will depend what you have access to. So I think Queensland does quite a lot of drain related safety. And I know the BTS has also got some online resources in that regard, but it really depends what people have access to. Yeah, and just keeping up to date with articles and papers that come out. I think for me, I find it are the most useful to see where we're headed and potential new uses as time goes on.
Absolutely. Yeah. And I think the other thing I'll add from my experience is just, I mean, some of this is a numbers game, right? So, and it's relatively easy, right? So you just get an ultrasound. I mean, especially if you go to the ED or something in any tertiary care center, they're just floating around, usually eating dust. So I
Right.
think mostly it's a numbers game, just so, don't be afraid to just grab, I think for our junior trainees, just to grab an ultrasound and just go at it and give it a shot. You're not going to hurt anybody with it.
Yeah.
And I think so. Just trying to see as much as you can, because I think the more you see, just like a CT scan, the more you see them, the more you find the abnormalities or some nuance that may be helpful clinically.
That's right. I think actually that's probably the biggest value to having a portable device, handheld device. Practice in amongst all of these other things that are important. I think you're only ever going to progress and learn from your mistakes as in many other areas, but in terms of how you hold the probe, how hard you push on a patient's skin, particularly in a bigger patient, all of that just comes with sheer numbers that you're seeing and you're doing over and over again.
Absolutely. Great. All right, so I'll finish up there then, and really thank you again for joining us and giving us this great talk. What I'll say with our audience is please join us next month. We'll have Dr. Ed Fish talking about pleural effusions in the ICU setting and management of such. So thanks again for everybody joining in, and we'll see you next month.
Thank you. Bye-bye.